Hello, everybody. Welcome back to our series of podcasts that we call Menninger Mindscape. Today, we're delighted to have Dr. Shawn Shea, who's going to be one of the speakers in our symposium tomorrow, which is entitled The Problem of Suicide. And Dr. Shea is from New Hampshire, traveled a long way to get here, and we're delighted that you're going to join us. I'll just say a word or two. There's a whole lot I could say to introduce Shawn, but he is president and director of what's called the Training Institute for Suicide Assessment and Clinical Interviewing. And one of the things that he's really become well known for, and actually you give workshops all over the world, about interviewing technique, and then that can be focused on how to interview a patient or to elicit information that addresses the problem of suicide and suicide risk. Dr. Shea has written a lot. I'll mention two books. One is called Psychiatric Interviewing, The Art of Understanding, and it's in its second edition, but the third edition is coming out next year, I think, and is in the works.
Hopefully.
Right. And another called The Practical Art of Suicide Assessment, and this focuses on a very interesting strategy that he's developed, and will tell us a whole lot more about tomorrow, called the Chronological Assessment of Suicide Events, or the CASE method. So there are a lot of other things that you've done, Shawn, but let me turn it over to you. Just tell us a little bit of a sort of teaser for what we'll hear more about tomorrow.
Well, I'm, once again, it's a great honor to be here. And I have a particular interest in clinical interviewing. In fact, that's basically the field that I've come out of and sort of then moved into suicidology as well. I had a rare opportunity early in my career, a few decades ago, to at Western Psychiatric Institute Clinic. I ran their assessment center and their emergency room. And
I know that department well.
It's a great place. It's a wonderful place. And one of the things that was interesting in that was that obviously interviewing was the name of the game, John. And not only that, but then interviewing in very difficult things, uncovering incest, uncovering homicide, and of course uncovering suicide. One of the rare opportunities was that up until 11 o'clock at night at that point in time, everybody who came into our center was double interviewed. They would be interviewed if it was an emergency room about 20 to 30 minutes, if it was a full intake about 60 minutes, and then always that frontline clinician, which were various different disciplines and trainees, and also we had a magnificent group of master level nurse clinicians. They would then give their impressions to a faculty member, and then the faculty member would walk in and do usually about 10 to 15 minutes more of interviewing, sculpting what they needed to know. But if you think about it, what an opportunity for someone who wants to study interviewing. Because as the director, I would sometimes watch the entire process. So I got to see two different interviewers interface with a human being who is in pain, and I got to see what the difference in the interaction was. And I got to see people who had great experience, people from different disciplines, and the one thing I came away from that was embedded forever for me, they got different data.
Isn't that interesting? Inter-rater reliability was not
radically, even to the point with some people uncovering a full-blown suicide attempt, whereas the first clinician had no idea such an attempt had occurred. By the way, I must add, it was not always the experienced clinician who was the better interviewer.
Well, that's important to add.
It's very
That's very interesting.
So what? Oh, go ahead.
So experienced clinicians can have worked with patients, had patients where there have been suicide issues as part of the problem, and not really realize that they're not getting to the real important information that the patient may not be telling.
Oh, absolutely. Yeah. I mean, people have walked out of a clinician's office and shot themselves in the parking lot. So obviously that clinician was unaware of what was going on. And that doesn't mean they had a bad bond, which was the other thing, is it's not, first of all, what we learned was that we started to sit back, sort of like the proverbial bug on a wall, and just watch the clinicians and literally code out what words they used. And we came to realize there were very specific interviewing techniques that you could decipher. Many times the clinicians did not know that they were even doing it. They'd modeled it off of another clinician. But we would take that, I'll give you just one clean example of it. I've probably watched over 400 full intakes from front to back, whether emergency room or full assessments. So I've watched, at least 400 clinicians doing frontline suicide assessments as part of that. After a clinician uncovers let's say a method, let's say the person overdosed. The most typical, every clinician knows, well, I have to find out if there's other methods. The most typical thing a clinician will say is, if you were my patient, I'd say, John, have you thought of any other ways of killing yourself? Very common. But actually, in interviewing literature, it's been found from sex researchers that that is not as an effective a question, have you, as opposed to gently assuming the person has done something. So instead, sex researchers have found, and clinicians, that if you turn to the person and say, John, what other ways have you thought of killing yourself?
Right.
Man, it pulls stuff out. So it's not just the issue that you have, it's taking those interviewing techniques, always embedding them in empathy. That has to be there. But it's not empathy alone. It is technique.
That's very interesting. So you're going to tell us more about that tomorrow, and just we'll have a chance to really hear it at length. But what you're describing is based on an assumption. And the assumption is that you're asking about suicide.
Right.
But we know a lot of times in the health professions, patients have this problem, but nobody asks.
Right.
And you were telling me a little bit earlier about sort of the prevalence of the seeing a health professional for people who later suicide.
Right.
Tell me that again.
Well, one thing that research has definitely shown is that about 50% of people who die by a suicide have actually seen a primary care physician or nurse or PA within 1 month of the actual suicide. And at one level, that sounds like a very disturbing number. Actually, I find it phenomenally hope-producing. Because what that means is that 50% of the deaths in America of a suicide, 50% of the time, the person is in a room with a professional. So that if we could just get the professional to ask, but not only ask, but then learn how to pursue. Because one of the things that even mental health professionals frequently don't think about is that the people who are most dangerous, who most want to die, they will probably be cagey about what they respond when first asked.
Well, but I think this is so important. And I agree with you, it's hopeful, except it's hugely challenging.
Yes.
Because that's the population that so far, even though they were trained in their health trainings, whether it's a nurse or a psychiatrist or an internist, that these were important things in a mental status to check out. It doesn't happen that much. I mentioned to you when we were chatting earlier that during the year when I was at the APA as president, I selected integrated care as the theme for the year. Because I really think we have to be in the room side by side with internists, primary care docs, pediatrician, family docs, and working together. But the role and the challenge of asking about these things should not be only limited to those trained in mental health. We have to help people understand that it's part of their job to include this just as much as to take a blood pressure.
Absolutely. And the bottom line is the question is, well, why they don't ask. And when you say that they were trained, in their professional, they were, very few of them were trained. Okay, what I mean by training is not only do you understand the theory, you are experientially trained. Someone coaches you. They watch you ask the questions. So why don't people ask? Well, primary care physicians or nurses or nurse clinicians, and by the way, nurse clinicians, our staff with all the frontline were they're amazingly adept at this.
Oh, I agree.
When well trained, obviously. But the thing that was fascinating about that is why does a person not do something? I don't know about you, but I don't do something if I don't feel competent in it. So if they're not trained, why would you why would you want to raise suicide, which is a frightening thing even to mental health professionals? If you're not trained to do it well, you're probably not going to do it.
Well, and also I've found that sometimes it doesn't get raised, not because the person doesn't think of it, but there's a real aversion to bringing up something that if the answer is yes,
that's another ballgame.
It makes me very uncomfortable. I'm not sure what my responsibility is going to be, and I'm not sure what I should do about it. But if I don't ask?
Well, one of the things that I'll be talking about a lot tomorrow is, the bottom line is, and all that work started at Western, has been developing for 20 years since then. And we developed an interview strategy for uncovering suicidal ideation, behavior, planning, and intent. It's called the chronological assessment of suicide events. The literature is just called the CASE approach as an acronym. The CASE approach, and I put another bias here, which I just shared. I really believe that although risk and protective factors are important in understanding, and they have some help for us. In other words, a classic place where they're of use. A person flatly denies suicide, no matter how much you press. You understand risk and protective factors, you look at their risk and protective factors, you go, oh my gosh, it's hard to believe he's not. And you say, you know what, I need to call his wife. And the wife says, thank God, talking to him, he's done nothing but talk about suicide. Well, there you probably save somebody's life from your understanding of risk and protective factors. But on the other hand, the push of the field, I think, for decades to hunt for what I think is a unicorn, an algorithm of, if you put this soup together, it will.
There's no formula.
No, there's no, and there never will be, because people don't kill themselves because they fit a set of statistics.
Well, listen, I'm going to interrupt only because we're going to run out of time, and we're going to have more time tomorrow, so I look forward to it. I do want to tell the audience that you have a website, I believe, where you have a lot of material that would be very interesting to those who'd like to learn more about what Dr. Shea does, and that's www.suicideassessment.com.
Yes, and on that website there's PDFs on an entire monograph on the case approach. There's a PDF on how to teach it. There's a PDF on how to train people to make interviews conversational as opposed to feeling like I'm being interviewed. Also, a favorite thing on the site is a thing called an interviewing tip of the month. They're not my tips, they're tips that readers send. So anybody who sees this podcast can certainly enjoy the tip of the month, but if you have interviewing tips on any topic, we love to see them and we post them.
Okay, great. Well, look, I really look forward to hearing your talk tomorrow. We'll learn a lot more about it. But thank you for teasing us a little bit with this today.
Thank you.
And thanks to all of you for watching, and we'll see you again next time.